Hello, and welcome to Next Fertility Nordic's podcast. This episode is in English. I'm Samantha, and I'm sharing my experience as a biopsy technician and the clinical relevance of PGTA. Happy listening. So, a little small introduction about me. I completed my education in the UK with a Master's of Medical Science in Assisted Reproduction Technology, and then I did my training in Canada. I joined the clinic 5 years ago when the new lab opened at the Verenni location. So, as you may know, embryology is not so well known in Estonia. There's not many of us. And there's actually not a specific academic program in order to study embryology here. So that can sometimes be a limitation when young individuals are looking to get into the field. Now, let's talk about pre-implantation genetic testing, or PGT for short, since it's becoming more popular as an add-on service to every IVF cycle. So why is PGT becoming so relevant in modern fertility treatment? Well, society is definitely aging. There is a clear decline in birth rates in Europe and in Estonia particularly. So the average number of children per woman is actually 1.2 at the moment. Women are giving birth later on. The average age is 31 years old. And in 2024, under 10,000 babies were born in Estonia. Now, advanced maternal age, believe it or not, is actually at the age of 35. So if you ask many 35-year-olds, they probably don't consider themselves old. But unfortunately, in reproductive terms, then we are talking about advanced maternal age. Now, to understand a little bit easier, PGT, we're talking only today about chromosomal abnormalities, since there is a small population of patients that have structural rearrangements or monogenetic diseases, but it's not so popular, so we won't talk about it today. However, one example when PGTM might be necessary, especially in Estonia, is surrounding the deafness gene. So there may be a circumstance where in a couple, both of the patients actually are carriers for the deafness gene. And this can mean if they have a baby, their baby could inherit this deafness gene. So one way to prevent this is if one of the patients has a carrier screening test, they can see if they're a carrier of any of these disorders. By chance, if they are a carrier, then their partner can come and have the same test just to make sure that they're not the carrier of the same genetic disorder. And that means that they won't then pass that trait onto their offspring. So that's one example. The carrier test is just a simple blood test. And after that, the patients could do PGTM if they're both carriers. So how do we actually do PGT? Well, in the lab, it involves an embryo biopsy. So just to give you a little bit of background about that, what happens is on day 5 or day 6 of development, any suitable blastocysts that have grown in the lab, they actually have a few cells removed. So we remove about 4 to 8 cells. And the way we get the cells is by making a small hole in the outside zona. We're using a laser, and then we go in with a micropipette. We aspirate these couple of cells, and then we put the cells in a very small tube, and then we send the tube off to a genetics lab. So the genetics lab are looking at each embryo, and they're looking to see what's the genetic composition of each. Then they will report it on a patient report, and then after that, the patients can make a decision about their embryo transfer procedure. It takes about 2 weeks for the results to come back. And then after that, if there are any normal embryos, then the patient can have their medication for a frozen embryo transfer cycle. So in 2025, so last year, we biopsied 182 embryos during 48 patient cycles. The average number of embryos that we sent per cycle was 3.8. So what are the likely categories that patients may have their embryos? They can have euploid, aneuploid, complex aneuploid, high-level mosaic, low-level mosaic, or non-informative. So just to make this simple, let's talk about normal versus abnormal. Actually, 64% of all of the embryos tested, they did not come back as normal. So many patients actually received a result where they didn't have any embryos suitable for transfer. Now, how might a patient feel about this? Well, ideally, they would come into their cycle with realistic expectations based on their age and their medical history. Some patients may have previously had a miscarriage, and so they're undergoing the genetic test to understand perhaps more about why that pregnancy didn't progress. And then in those cases, they are expecting some abnormal embryos. Even when the results show abnormal embryos, we can think of this as a silver lining because it avoids patients wasting time on having multiple embryo transfers, which will ultimately fail. And this matters a lot after the age of 39, where time is really of the essence. So getting these PGT results in means that patients can start a new cycle sooner if they need to, and this can really help. So once the results come back, patients may feel a little bit confused, and that's why we recommend to have a consultation with an embryologist. This can really just give closure to the cycle and help the patients to understand what their next steps are. If you've received a result with mosaic embryo, we would advise to talk to a genetic counselor to just help you better understand if these low mosaics should be transferred or not. So why don't we have transfers of abnormal embryos? Well, simply, they don't have any chance of having a live birth. So last year, 116 of these embryos were abnormal, and we want to make sure that the patients are not having these embryos transferred because likely is that they won't implant, so they'll produce a negative pregnancy test. But on some instances, they would likely to have a clinical pregnancy followed by a miscarriage. In the very rare instances, a child may be born with a genetic disorder as a result of the aneuploidy. However, most of the aneuploidies are not compatible with human life, which means they would never really get to that stage. And there have been studies showing what actually happens when you transfer an aneuploid embryo, and they had a 0 to 0.5 chance of a live birth. So it's really actually unethical to be transferring these embryos. Now, on a more positive note, let's talk about our success with PGT. So last year, the results were very high per embryo transfer. And actually, the best performing group was those at the age 40 or above. And in this instance, if you were 40 or above and you had PGT and you had a euploid embryo transfer, you actually had a 63% chance of having a clinical pregnancy and a 50% chance of that pregnancy being ongoing, so going up to live birth. And this is when using own eggs. So as a result of this, the doctors at our clinic are really starting to emphasize the importance of adding PGT to your cycle, especially when you're aged 38 or above. The results really are speaking for themselves, and we want to avoid patients having false hope. We want to avoid patients having emotional or physical trauma from having a miscarriage. And we want to make sure patients are having the best chance of pregnancy every embryo transfer. So we want to reduce the amount of transfers that patients are actually having to go through because that's time spent having medication and it's also costly. So are there any instances where PGT is not so useful? And we see that when patients are using their own eggs and they're 34 or under, or if they're using donor eggs, then actually PGT does not on average increase the chance of clinical pregnancy. So whether you have PGT or not, you're sort of in the same position. So let's talk a little bit about embryo selection. So how do embryologists actually choose embryos for freezing or for transfer? Well, we look at the embryo's morphology, we look at the video of how normal the embryo was developing, and we also go back to the fertilization and have a look at any lab notes based on freezing or fertilization. Now, there are some surprises when it comes to which embryo is the best, and that's when we compare what we consider the top embryo, and then we look at the PGT report and we see actually this beautiful looking embryo is abnormal, and the lower quality embryo actually turned out to be normal. So that's why we definitely prioritize the PGT result when choosing an embryo. Thereafter, we would look at the morphology and we would choose the normal embryo that had the best grade. So transferring a euploid embryo will never be 100%, unfortunately. So actually, it doesn't guarantee having a pregnancy. But let's talk a little bit about why this might be. So if a patient is having euploid embryo transfers and they're failing to get pregnant, this may suggest there's something else going on other than advanced maternal age. So for example, they're having true recurrent implantation failure, and this might be due to endometrial thickness. So they're not responding to the medication, and then it's affecting their lining. Also, there may be some problem with endometrial receptivity, so the uterus is not at the optimal position to be taking or having this embryo implanted. There can be some immunological factors that can influence implantation, as well as other things like de novo mutations after the embryo is transferred. So let's briefly discuss any risks of the procedure. So misdiagnosis is around 2% chance. Also, sometimes embryos come back as inconclusive, and this occurred with us 2% of the time. So it meant that the DNA that the genetics lab received, they were not able to actually analyze it, and they were not able to give an accurate result. So in these situations, we might want to rebiopsy and refreeze if the situation allows for it, but there can be some concern that this would cause some stress on the embryo. What other complications do we see? Well, when you're performing a low quality embryo, for example, a CC quality grade, or if the embryo has been previously frozen, some technical challenges can arise. There may be limited cells on the outside of the embryo, and so if you remove too many of these cells, it could compromise the embryo's viability. However, if you don't remove enough cells, then the DNA might not be sufficient and you may not get a result for this embryo. So it's a sort of risk analysis. But we definitely don't advise to freeze and thaw embryos multiple times. So we want to try and do a biopsy fresh where possible, as we want to make sure that each embryo has the best chance of surviving and also the best chance of implanting. So in the lab, when we're thawing these biopsied embryos, we're seeing them expand nicely just before transfer. And this means, or it shows to us, that these embryos survived the biopsy process, they survived the thawing and the freezing, and they're ready to be implanted. So let's end with one last thought about what you should understand before choosing PGT. Definitely the feedback that we've got is that it's really hard to wait for this 2-week period whilst waiting for the results. So you may know how many embryos were biopsied, but you don't actually know the results of these. So you don't know whether you will be able to have an embryo transfer. If there is a chance that you will not have embryos for transfer, it should be a good idea to mentally prepare for this, in the fact that you might need to have a repeat cycle in order to generate more embryos for testing. So that's just something to keep in mind before going for the biopsy. And if you have any follow-up questions, then you're welcome to write to us. Our email is lab@ivfnordic.com. Thanks for listening.